I'm Malati Srinivasan,
And I'm Leah Milheiser.
and today we'll be your faculty discussants talking about an approach to female sexual dysfunction.
We have the following disclosures and you can review them here.
Great. And we just want to have a disclaimer. This talk, as you know, is meant for medical professionals and is a sexual health talk. So there will be some images that will be have explicit images of female sexual organs. So if that's of concern to you, just please be warned. Our learning objectives today are to help people in primary care develop a systematic approach to female sexual dysfunction and female sexual concerns. We want you to learn what to say to patients, to create a comfortable environment to discuss your sexual health. And we will walk you through 3 common female sexual concerns that you'll see in clinic. And we'd like you to consider how to treat the patients, considering emerging therapies and also the limits of evidence. So historically, female sexual health has been a taboo topic, and we know that's changing. The Greeks used to consider the uterus a wandering organ and contributing to women's hysteria. Different cultures embrace sexual health in different ways. Some were very closed, and it was something that you only talked about behind closed doors, whereas others were more open in their discussions and more welcoming of issues surrounding women's sexual health. But there has been fear and shaming and sometimes gaslighting historically of concerns that women would bring up when they would talk about their sexual health. And I know that's changing. So Dr. Milheiser, I know there's been a sea change over the past 20 years. Maybe you can tell us a little bit about that.
Yeah, so we, prior to 1998, 2000 era, we really didn't talk much about female sexual medicine. There wasn't a field. We certainly had male sexual medicine with the advent of the little blue pill sildenafil, which was the impetus for developing treatment and understanding more about what the causes of female sexual dysfunction were and what the disorders were for female sexual dysfunction. So we are actually grateful to Viagra for actually being the cause and the explosion around research and understanding in this space. So, back in 2000, we had 0 FDA-approved treatments for female sexual dysfunction. Fast forward to today, we have 6. Is that great? Not really, considering there are, over 25 treatments for male sexual dysfunction, and male sexual concerns are less common than female sexual concerns. So we are certainly on the pathway to have more treatment options FDA approved in the next few years, certainly a lot of the pipeline, but we are not where we'd like to be. But at least we have some options available, and we'll talk about those today.
Great. And, one of the questions I think that a lot of people have is whether or not female sexual health is actually an issue in primary care. I know that a lot of us don't routinely ask about female sexual concerns, and maybe you can share some of the data.
Yeah, well, we certainly should be talking about female sexual concerns and inquiring about them from our patients, because actually we know from research that a female sexual concern can be a sign of an underlying health issue. So why is it important? Well, 44% of women in the United States between the ages of 18 and 102 have a sexual concern. Now, that's different from sexual dysfunction. To meet sexual dysfunction criteria, you have to have personal distress or impairment associated with that concern. So about 12% of women have dysfunction, and about 44% just have a concern in general. So why is it important then to talk about, things like HSDD, low libido, other sexual problems? Well, because it's not just about their sexual function. It's about how the sexual function affects their relationship, affects their life. I think about it like an octopus with tentacles that's really impacting multiple areas of their life. We know that it affects pre- and postmenopausal women. Some things affect premenopausal and postmenopausal differently. So we know that women may feel less connected to their partner. There may be less communication. They're worried that their partner will cheat. This is a very big issue I see in my clinic. There's arguments about sexual function. There's, worried that their partner is going to leave, as I said, and for some it has no effects. So I want you to keep in mind that it's not just about the actual dysfunction or concern. It's about how it's affecting her and her relationship.
Yeah, and I think that's such an important point that we have to really look at female sexual function very holistically keeping in mind things having to do with their psychological issues, whether it's stress or depression and alcohol, or sociocultural things, how they were raised, interpersonal issues with their partner, and also physiologic changes they may be going through, whether it's from hormones or medications or illness. And I know that there's also a lot of medications that can impact sexual function, Dr. Mulheiser.
Yeah, it's hard to see a patient who's on a medication that doesn't impact her sexual function, to be honest. So I want to give you an example from my field, which is birth control pills. We know that birth control pills, although a wonderful medication and has many different functions, can cause low libido, can cause painful intercourse. We know that patients who go on aromatase inhibitors for breast cancer have significant difficulty with pain during intercourse, vaginal dryness. And you can see there's a whole list here. This is not the entire list, but this is certainly some of the more common medications that we in primary care and in gynecological health are giving to our patients.
Yeah, and we see the same thing with the impact of chronic illness on female sexual function. All of the major illnesses, diabetes, hypertension, heart disease, hypothyroidism, peripheral vascular disease, multiple sclerosis, the other autoimmune diseases, all of them affect female genital arousal and desire, orgasm, and a lot of pain. So it seems like we have a long way to go to be able to help our patients. And I wanted to bring up another question that some of my residents had asked me in the past couple of weeks, which is, what's considered normal? What's a normal sexual response? And when we're kind of saying people are having concerns, how do we actually know if what they're having is normal?
So we have to think about just the heterogeneity of female sexual response. So we know that throughout a woman's lifetime, whether it's her relationship, her hormonal profile, whatever psychosocial stressors she has in her life, those can all affect her sexual function. And so we need to think about the background of what is the sexual response cycle and what do we know as, quote, normal. And I want to caution everyone, when we talk to patients, it's important to keep normal out of our lexicon, because in actuality, and if you can go to the next slide, we can sort of talk about this a little bit more. There is no normal throughout a woman's lifetime in her lifespan. It changes, her response changes, and it changes because of all the things that I just talked about. Now, I want to show you this linear cycle. There's two of them here. One is Masters and Johnson. This was the original. We know that these are the original pioneers in sexual medicine, but they came up with a human sexual response cycle, right? Which started with arousal, eventually led to orgasm, and then everything sets back to zero. Another research after them came around and said, listen, this doesn't really apply to women. Women need to have desire, then they become aroused, and then they have an orgasm. And there shouldn't be resolution, because resolution is the lack of sexual response. So from the 1960s up until about 2003, this is what we used as male and female sexual response. But what we learned over the years, and again, post Viagra, is that women, first of all, don't always have spontaneous sexual desire. We also understand that genital desire and central arousal don't necessarily, or central desire, don't necessarily match. We know that women don't tend to fantasize sexually the way that men do. And so all of this sort of came together, and importantly, that orgasm does not have to happen, but all of this came together to say, we have more of a circular, women have more of a circular sexual response, not linear. So this is what was proposed as the new female sexual response cycle in the early 2000s. It's based on intimacy, and it also takes into account that spontaneous sex drive isn't always there. It might be, but it isn't always. And for those women who don't always have that spontaneous desire, intimacy may be their goal. So that is what they are starting with. So they seek out a sexual stimulus, and if all the stars are aligned, they may develop a responsive sexual desire and arousal during the act. So she didn't start in the mood, but she gets in the mood during the act. She then may or may not have an orgasm. Notice here, orgasm has been taken out. We understand that women do not always need an orgasm to be sexually satisfied. Now, the thing is, if she is trying to have an orgasm and she cannot, then that could be a sign of a sexual disorder, which needs to be evaluated. And the one thing I want to tell you, and this is really important because I know a lot of people in the audience are saying, well, actually, I think I align more with the Masters and Johnson or with the Kaplan. We know that women can endorse all three of these sexual response cycles throughout their lifetime. And it changes, again, heterogeneity of female sexual response. You may be young or in a new relationship, or all of your hormones are where they're supposed to be, and you're more Master and Johnson. Or you're postmenopausal, you've been with your partner for, 35, 40 years, and you're more, this is called the Besson, the circular model is called the Besson model. You may be more the Besson model. So just keep in mind that it can change with your situation.
Great. That's so helpful. I think that gives us a really good framework. And, the other thing is I find a lot of the nomenclature around female sexual concerns and dysfunction very confusing. Maybe you can just hit a couple of the highlights for us in terms of how we talk about this and how we can talk about it with ourselves and our referrals, with our colleagues, and with our patients.
Yeah. So, when we talk about sexual disorders, that really has been within the psychiatric world. So within the DSM-5, that's where they are listed. Now, you can see here listed DSM-4 criteria, which then converted to DSM-5 in 2013. So again, this is what the mental health practitioners use to describe female sexual disorders. I don't want to get too much into it because there's a little bit of controversy around this, but just to understand that most of us in clinical practice who are doing more of the physiologic medicine ascribe to the ISWISH nomenclature, which maintains hypoactive sexual desire disorder, which is a chronic, so more than 6 months happening most of the time, decreased or absent sexual desire, decreased or absent responsive desire, which we just talked about, really not thinking about sex, really not getting in the mood. We have female sexual arousal disorder, which is broken down into central arousal, so what's happening in the brain, and then genital arousal disorder, which is a vascular or neurologic issue. We have persistent genital arousal, which is a newer defined sexual dysfunction, which is somebody who has persistent arousal symptoms. We have the female orgasm disorders, which has to do with difficulty achieving. There's issues with latency. There's issues with how intense the orgasm is. And then you have something called female orgasmic illness syndrome, which has to do with aversive type symptoms that a woman can experience either before, during, or after the orgasm. It doesn't affect the orgasm, but these are symptoms that she's experiencing. And then, of course, the pain syndromes are still there, but just not in this nomenclature where they were focused primarily on orgasm, arousal, and desire.
Right. So helpful. I think this is going to help us communicate better with our colleagues and also with our patients. One of the things I think in primary care is we're very good about taking a detailed, thoughtful, welcoming history. And because so many of us grew up in families where sexual health was not something that we talked about, and certainly when I was training in medical school, this wasn't a big focus for female sexual health. We're encouraging you to think about using a framework to be able to bring patients into the conversation about their sexual health, so that we can actually elicit their concerns for those 44% of women who have concerns. And the framework that Dr. Milheiser has asked us to think of using is the ALLOW framework developed by Sadowski, which asks us to ask, legitimize, think about ask the women about their concerns, legitimize, and sort of put into perspective with an ubiquity framework what they are going through. And invite them into the conversation. I think about whether or not we actually want to take care of this patient's issues primarily or refer out, and then begin a little bit more workup discussion and then develop on working a treatment plan together. So this is basically what we would do in primary care with the added steps of the framing and then also making that central decision about whether to refer out early or not. And the way we can bring this up, just giving people words to use, is to say something along the lines of, in the United States, about 44% of women report having a concern with their sexual function. Do you have any concerns about your own sexual health that you'd like to discuss with us today? And it's a nice way of using the kind of invitation that we do for everything from pain and family issues and trauma and other mental health issues that we can apply also to this very sensitive subject, where we have to be very careful and mindful of where the patient is, pay attention to their body language. And one of the important things that we do for any sensitive topic is always ask permission and set some boundaries. So you might want to say something like sex is a normal part of human relationships and personal health. Are you comfortable talking about your sexual health? If it's okay, can I ask about this? And just really give them time, invite them into the conversation, and also set some boundaries so they feel comfortable saying no. If anything makes you uncomfortable, please let us know. And are there things that you prefer not to talk about? You may not do this with every patient, but there's probably going to be a couple that you might.
There's one thing that I would add to this that's really important is being mindful of your body language. Sometimes when we are uncomfortable with the topic of sex, and many of us are, it's hard for us to break through our own comfort zone. We might get uncomfortable, we're crossing our arms, we are, sitting above our patient in some situations. We have other people in the room. So for example, if she has a partner in the room, she may not want to talk about it in front of somebody else. So just be mindful of what your own body language is, that you're not being judgmental and how you're talking to them, that you're asking them if it's okay to have that person in the room as you talk about it. And also ensuring that there is adequate privacy for them to talk about it is really, really important, because otherwise you'll see these patients shut down very quickly and not talk about it at all and walk away without their issue getting even addressed.
Exactly. And having that moment of privacy for anything that's very sensitive is so important. So such a good reminder. I'm not going to go through, I think that we know how to take a general history. And there's a couple of questions that you may want to consider adding to your repertoire when you start talking about taking a sexual history. I'm not going to go through all of these, but for instance, being comfortable asking, have you ever been sexually active? Sexual activity can mean different things to different people. Are you currently involved in a sexual relationship? Who do you prefer to be with, men, women, both, or others? Do you have any concerns about being not sexually active at this point in time? And then really go through things that have to do with trauma and risk factors and intimacy and that entire biopsychosocial model that we went through earlier. There's additional questions that you can ask, which you'll be getting these reference slides, which you can review. But an important thing, I think, especially in primary care, where this is not where we spend most of our time, is to ask ourselves, what kind of training do I have? How far do I want to take the steps in training? Understanding that our partners in gynecology have limited bandwidth, and a lot of the initial screening and treatment, I'm hoping, will start to be done a little bit more systematically by primary care. And if you do decide that you're going to take on part of this or all of their sexual health care, you have to ask yourself, when do you have actually time to talk about this? Do you want to do it now or later? Are there other conflicting things going on? And what resources do you have, which we'll be going through in a little while with you. After that, you want to really think through the sexual history, perform an exam, but only if necessary. For people who have a low libido or a few other things, you may not actually need to do a physical examination. And Dr. Milheiser has made the point that sometimes when you do a physical examination inappropriately at the wrong time, you can actually break trust with the patient. So, be judicious in what you do and use your standard clinical judgment to figure out what's appropriate. And we'll talk a little bit about lab testing. And finally, the last part of the allow framework is to think about collaborative decision making, and invite the patient in, because this is their life and we're trying to make a part of their life that's very personal better for them, so that they can have a more fulfilling life in whatever way they want to be fulfilled. So saying things like, we've discussed a couple options for this today. What do you think? Where should we start? If we get stuck, or if we decide that something is out of our scope of practice, would you like a referral to specialists? And these include a whole bunch of people that you can see here. So I think that'll help us open up the conversation. And I'm hoping that Dr. Milheiser can talk to us a little bit about a treatment framework that we can use as we're beginning to think about, once we've started to diagnose a patient, what we actually want to do. And I promise you we'll get to the cases.
So when we think about treatment approach, of course, we're thinking about what is the primary sexual health complaint. And I want to just really emphasize that when a patient comes to you with multiple sexual complaints, try to identify what was the primary presenting complaint, because typically when you treat that, then those subsequent complaints that they have will improve. So go after that primary one first. So we're going to really start to think about and if you can go back to that slide, actually, Dr. Srinivasan, I think that would be helpful. So you really want to think about your histories and then your labs and then your exam, as we just discussed. You might engage in partner education in addition to patient education. So I'm going to give you a great example. I had a patient and her partner in my office, and she asked me specifically if he could join us so he could learn about what she was learning about. And so he can understand what her condition is and how to best approach it and be a supportive partner. So I always ask my patients, would you like your partner to be involved in this conversation? Sometimes they say yes, sometimes they say no. And then, of course, we go to what the treatment options are, whether that's medical therapy, whether that's behavioral therapy, or whether that's something like pelvic floor physical therapy. And then why don't we go to the next slide and we can jump right into how we approach this.
Is this sexual health complaints? Is this the slide you want?
The next one. Yeah.
Great.
Thank you.
Yeah. So, I think that, again, we're in primary care very comfortable taking a sexual history, or at least knowing what to ask for a general complaint. Someone comes in, onset, duration. Is it lifelong? Is it acquired, precipitating events? What makes things better or worse? Duration, clinical course. But there's some specific things I think we should think about as well, relating to their partner, whether their issue is place specific, if they've had a history of trauma, impact of culture and values, if they're mindful during sex, if there's effective techniques they've used to be able to address their issue on their own, their risk-taking behaviors, and their spectrum of sexual practices. And I know, Dr. Milheiser, there's a couple tools. We're going to go through one in detail later, but some tools that we can use to be able to screen for this.
Yeah, so there are a couple different validated questionnaires that you can use. I'm going to be very honest that the only one I really use at this point in my career is occasionally the DSDS, which is the Decreased Sexual Desire Screener. This was actually a validated tool for diagnosing acquired generalized hypoactive sexual desire disorder. So it's a 5-item questionnaire, very easy to do in the clinic. If you think about what sexual dysfunction is, it is a complaint, a persistent complaint associated with distress. So if you are following someone over time, you can follow their distress by doing the validated female sexual distress scale. You can do the female sexual function index, which is one of the original validated questionnaires that helps you. This is more of a research tool, but it might help you if you're early in your practice of female sexual medicine to identify what the sexual concern is. So it helps you identify. I wouldn't really use it though for treatment. It's just to help you identify. And then of course the FSDSR is for distress, and then your decreased sexual desire screener is for identifying HSDD. There are other screeners out there. There are many. You just need to find, those are the most generally used ones. You need to find the ones that are most applicable to your practice. So those are a good starting point. Now, when we talk about doing lab tests, this is really important. You've got to use your clinical judgment. We do not do labs across the board. So there's no universally agreed upon panel for the evaluation of female sexual concerns, right? So we look at a patient, for example, who has HSDD. HSDD is the most common sexual disorder in women in the United States. So I'm thinking about what are the other medical conditions that may be contributing, because HSDD, if it's truly generalized acquired, it is a neurobiological issue where they have lowered dopamine, norepinephrine, and slightly increased serotonin. But other conditions can lead to low libido. So if somebody has fatigue, if they have symptoms that are consistent with hypothyroidism, I might be checking a TSH. If they, and this is a little more rare, if they have signs or symptoms of testosterone insufficiency or signs or symptoms of a prolactinoma, I'm checking their prolactin level. If they have, again, signs or symptoms of testosterone insufficiency, I might check a testosterone, but it is not very common to see a premenopausal woman with androgen or testosterone insufficiency. And in postmenopausal women, where we know their testosterone is going to be low just by the fact that they're postmenopausal, we're typically checking testosterone only if we're putting them on treatment with testosterone. So it's not really a way to diagnose because there is no agreed upon level of testosterone that says you have low libido because your testosterone is this. So again, keeping in mind that tailor your lab studies to what the complaint is. When we do a physical exam, again, not always indicated. If you have somebody who comes in with low libido, they have no pelvic concerns or complaints, please don't do a pelvic exam on them. If somebody has pain or orgasm concerns, yes, you're going to want to do it. So what are the things that we're looking for? Again, depending if they're pre or postmenopausal, I'm going to see different things. But in general, we're doing a visual inspection of all of the structures of the vulva, right? So we're looking at the clitoris, the clitoral hood. We're looking at the vestibule. We're looking for any signs of erythema. We're looking for pain of the vestibule by doing a Q-tip. And there's a very specific way to do that where you take a Q-tip and you touch in a clockwise fashion around the vestibule, which is the area around the opening of the vagina. And you're looking for any signs of pain. You're looking for redness around the glandular openings. You're looking for any adhesions of the clitoris to the hood or pain upon touching the clitoris. You're looking for abnormalities of the hymenal remnant. So sometimes patients will come in with pain and you'll find a septate hymen. It's not that common to find when women have sort of gotten older and they're postmenopausal to find somebody who has a abnormality of the hymenal ring, but you certainly may find it in a younger woman. You're looking for birth trauma, so obstetric lacerations that have led to scarring or neuromas, for example. So those are sort of the main things that you're looking for, and we will look at pictures of a premenopausal versus a postmenopausal vulva and vagina. Therapies that we think about, again, medical, behavioral, pelvic floor. I sort of lump sexual therapy into behavioral, but there are medications that are FDA approved, and there's certainly medications that we use off label because there is data to show that they are safe and effective. There are procedures, there are devices, some of them we endorse, some of them not as much, and there certainly are emerging treatments that we can talk about. For behavioral therapy, and I want to keep in mind that when you talk about treating sexual dysfunction, it is typically a multidisciplinary approach. It is not usual that you treat someone in isolation. So you want to make sure you have these referrals in your network because you're going to have to use them with your patients who have had long-term sexual dysfunction concerns.
Great. And, I think that this is such an important step to think about this multidisciplinary approach where primary care is partnering with gynecology to be able to communicate really smoothly about how to manage things, whether we're going to do an e-consult with gynecology or if we're going to actually send someone and have them be examined because they need additional services. A lot of my patients, I've talked to them about pelvic floor therapy and sexual therapists, and they're very confused about what these people do and what their training is, and when to what's going to happen when they go to see them. Could you tell us a little bit about both of those two specialties?
So a pelvic floor therapist is a licensed physical therapist with a specialty in working on the pelvic floor. So it just depends on what your condition is. Men and women both go to pelvic floor physical therapists, but if you're going for a sexual pain condition, they are typically doing work both on the abdominal wall as well as in the vagina. And so they are identifying where the pain point is. They're teaching patients how to, for example, relax the pelvic floor muscles. They're doing work on, if somebody has a hypertonic pelvic floor, they're looking for any sort of trigger points that they can treat. So it's really important to explain to your patients that this is an ongoing therapy. It's usually not a one and done kind of experience. They're going to go for several to many sessions. I've had patients who've been in PT for several years, depending on what the condition is. So pelvic floor physical therapists are just, for me as a gynecologist, one of my most important referrals, and I work so closely with them. And then sex therapists are similar to, a marriage family therapist or a psychologist or psychiatrist. However, their licensing is a little bit different. So anybody can become a sex therapist as long as you go through adequate training and education. The licensing board, like I said, is not there, but you can get certified by the American Association of Sexuality Educators, Counselors, and Therapists. So typically what I say to patients is look for an ASECT certified sex therapist or sex counselor. I typically will recommend that they find someone who already has a background in counseling, so psychology and MFT. Because you want to be very careful. Anyone can hang their hat and say they are a sex therapist. So find somebody who is certified. Sex therapists, and I get this question a lot, is a sex therapist going to make me have sex in front of them? This is a question that is not infrequent. And so what you need to explain to them is no, that is not, they're thinking of a sex surrogate. That's different. Sex therapists, just like any other therapist, are identifying a sexual problem. They're creating a problem list and they're addressing it from that perspective. If they identify an underlying mental health disorder in the patient, like depression, anxiety, they recommend that that get treated first before they work on the sex therapy part of their treatment. We are very fortunate at Stanford in that we have several patient resources available where they can access care to sexual function concerns. I started the female sexual medicine clinic about 20 years ago. I see patients who are experiencing all of the sexual disorders, especially very medically complex patients. In addition, we have the Women's Sexual Dysfunction Clinic, which is within the Department of Psychiatry and Women's Wellness. It is run by Dr. Julie Whiteloff, who is a clinical professor of psychiatry and behavioral sciences, and by courtesy, OBGYN. Julie actually provides evidence-based cognitive behavioral therapy for genital pain conditions, and we are thrilled to be able to collaborate with her and her colleagues in psychiatry.
Great. And we heard earlier today from Dr. Lania Kea and Dr. Mishra about the adult LGBTQ program. That's very cross-disciplinary, and for our patients who are LGBTQ+, they will be able to direct them to the appropriate psychological, physical, and other resources they need to be able to live their best lives. We also have a couple student resources. The major resource on the undergraduate campus is the Sexual Health Peer Resource Center, which is in Baden, which is, as you all know, is the student health center. And so the number, if students have questions or want information, they've got actually a stipend where they can have a certain amount of money that goes to them each month, or I think it's each quarter, to buy condoms or to buy lubricants and other kinds of stuff. It's 650-6X. Dr. Milheiser, you also had mentioned that there's quite a few other good resources in the community where we can both find some of these specialist providers and also get updated, accurate, patient-centered information. Could you walk us through a couple of them?
Yeah, so ISWISH is the International Society for the Study of Women's Sexual Health, and they really are the premier society for women's sexual health in this country. They also work collaboratively with international societies as well. They really set the guidelines, as we talked about before, the nomenclature for female sexual dysfunction, and have an annual meeting, which I highly recommend for anyone who's interested in sexual health. They also have great educational courses for physicians who are interested in entering the field of sexual medicine. The APTA is a great resource for finding a pelvic floor physical therapist in your area. So they have a find a provider section, as does ISWISH. ISWISH also has a find a provider section. These societies all do. Prosela is a patient-centered website that provides information about female sexual health and female sexual medicine, and it is supported by ISWISH, so it's very evidence-based, and I highly recommend patients visit that site. And then ASECT is the society that we talked about for sex therapists and educators and counselors. And if you want to find a certified sex therapist in your area, you would go to ASECT, and they have a section there.
It's wonderful. I think these are such valuable resources, and I'm going to make sure I bookmark them on my computer. We're going to transition now to 3 cases, and I know we've got a limited amount of time left. So what we're going to do is try to hit the highlights of them. And so these are 3 common sexual disorders that affect women that, as primary care physicians, you should all be able to recognize. And so the first case is a woman who we've probably all seen before. She's a 36-year-old woman we saw a couple months ago, whose sex drive has really been absent for the past year. She's in a really good relationship with her husband. They have had a great sex life. They've been married for about 8 years. And about a year ago, she noticed a big change in her libido, and it was happening all the time and causing her and her husband quite a bit of distress. You know, she's a lawyer. She cut back on work to work 3 days a week because her daughter is on the autism disorder spectrum and is very young. She's concerned because she and her husband aren't connecting in the same way anymore, that he might leave or cheat. And she's specifically been having sex weekly, even though she feels no desire, for the sake of the relationship, and she feels no spontaneous desire. There's very occasional responsive desire. She's not masturbating. She has a decrease in genital arousal during sex, and she needs a vibrator to achieve orgasm. Her social history and sexual history is fairly unremarkable. She's got no contributory past medical history. She feels pretty bonded with her husband. There's no violence. And again, her stressors are partly, she's working a lot. She feels like she's failing as a wife and as a mother. And as in life, her mom was also diagnosed with breast cancer recently. She's been flying back to the East Coast. So her goal, which ideally when you're talking with someone and asking them about these concerns, you may want to ask them also, what do you hope to achieve if we're able to treat this appropriately? She really wants to have sex again. And you can, of course, when someone comes to you, you're going to try to see if they have depression and her PHQ-2, which we screen for routinely for every patient who comes into primary care at Stanford on every visit, was normal. But Dr. Milheiser, you'd mentioned a validated questionnaire that is a good screener for decreased sexual desire.
The DSDS, that's what you're seeing on the right side of your screen. This is a very quick tool that you can use with your patients to help you identify generalized acquired HSDD. That means it's something new, they didn't have it before, versus lifelong, which we do see as well. So in this case, if a patient answers yes to questions 1 through 4 and no to all the items in question 5, then it's a clear-cut HSDD diagnosis. However, I'm going to tell you right now, most women will have concerns. If they have HSDD, there might be concerns in the relationship. Maybe they have some issues going on, psychosocial stressors that are causing them some emotional distress. So oftentimes you'll see women or individuals who will circle, well, yeah, there may be a medical condition, there may be a medication, I'm not sure. So you really have to tease out, is that medication, is that medical condition, is that psychosocial stressor the main cause of her low libido, or is it something that is in addition to this low libido that is always there? So typically, if it's 1 or 2 items that are circled, yes, it may be HSDD. If you have more than that, it probably isn't, and you really have to do more of a deep dive into their background. But if you see this type of answer sort of appearance to your DSDS, then this is definitely DSDS. And in this case, with this patient, she has it.
Yeah, absolutely. And I think that we've been pointing to this the entire time. The most common sexual concern for women and the generalized acquired hypoactive sexual desire disorder. And I know we've talked a little bit about exactly what that is. I was hoping that you might walk us through, Dr. Milheiser, some of the things that we would want to do as next steps for the patient. Do we need labs for the patient?
In this patient's scenario, I would not recommend labs. There's nothing pointing to that she has some sort of medical disorder that might be contributing. So I would say likely not in this patient.
Great. And how about referring her to a sex therapist with her husband?
Yeah, so this might be, I can tell you right now, if you say to the patient, oh God, sounds like, your libido isn't great, and I think I'm going to recommend you to see a sex therapist, you're going to see their face just, fall. And this is, I've heard about this, frequently in my career where patients come to me as a referral and they say, well, I'm here to see you because the only thing that's been recommended to me is therapy. These women will tell you, I have a good relationship. We're happy. Everything is good. I don't need a sex therapist. I've always loved sex. I just lost all drive and motivation. So I would say not a first-line intervention, but could come up later. So certainly if the lack of intimacy over time has caused sort of a disconnect amongst this couple when it comes to having sex, they might need a sex therapist.
Great. And you'd mentioned earlier that we generally would never start testosterone therapy on a premenopausal woman.
Yeah, unless this is truly diagnosed testosterone insufficiency syndrome, which again is not that common. It is not recommended treatment for a premenopausal woman. It is the recommended for postmenopausal just not for premenopausal. And, obviously there's a concern that if that woman gets pregnant, there could be virilization of a female fetus. So again, we're not thinking testosterone for these types of patients.
And how about some of the behavioral interventions? We talked about them a little bit earlier.
Yeah. So, behavioral interventions like going on date nights, incorporating sexual novelty, mindfulness, sensate focus, which we'll talk about, is always recommended. It's always important for a woman to, in a couple, to maintain relationship intimacy, which we can lose over time in a relationship. It's very normal, especially if there are kids involved or very stressful jobs. So we always recommend it. It may not be your, okay, you have HSDD, here's the first line approach, go out on dates. No, this woman clearly has a sexual dysfunction. And so we have to approach it in addition to behavioral. The primary treatment should probably be a medication therapy.
Great. And it's so exciting that we actually do have some CNS agents now for chronically low sex drive.
We do. It's very exciting. I mean, we talked about this before. HSDD is a condition, and we did the research at Stanford. We have areas of the brain that work a little bit differently in women with and without HSDD. And one of the things that we see, one of the problems, is that these women produce less norepinephrine and dopamine and more serotonin in the prefrontal cortex and hypothalamus. So we do have the medications. There are two that we're going to talk about. And I think, was there one more thing on that list?
There might have been. I think I might have skipped.
Yeah. So the last thing is whether or not we're going to refer a patient to a sexual medicine specialist as a primary care provider. If you are that person who says, you know what, I know my limitations, I am going to refer to someone else, certainly you can find someone on that iswish.org website, or maybe you have somebody in your academic center who treats sexual dysfunction. It may not be your first option, but just know that it is an option if you don't treat sexual function concerns.
And I know we've talked about this multidisciplinary approach to HSDD.
Yep. I think we can go to the next slide. We've talked through those. The two medications that are FDA approved for premenopausal HSDD are flibanserin, which is Addyi, and bremelanotide, which is Vyleesi. They both end up doing the same thing, which is elevating dopamine, norepinephrine, lowering serotonin, but they do it through different pathways. The mechanism of action of these drugs is not well understood, but we have animal studies, so we think that's how it works. The Addyi is given as a daily medication. It's given at bedtime. Some of the side effects include fatigue, nausea, dizziness. It can lower blood pressure a little bit. We typically say that results take about a month to see. If a woman does not, or an individual does not see improvement in 2 months, they should stop the medication. It's not going to work for them. In terms of alcohol, people ask me this all the time, isn't it contraindicated with alcohol? There used to be an alcohol contraindication. It was a black box warning. That is no longer there, but there are warnings around it. Alcohol can increase dizziness, low blood pressure, and possibly syncope. So the guidelines around it are, if you're going to take Addyi, stop drinking 2 hours before you take your Addyi, and don't drink more than 1 to 2 glasses of alcohol in a day. Vyleesi is a little bit different. It is an on-demand medication. So this is a subcutaneous injection. People are typically given 8 doses per month. We say not to go above that. So they're going to give themselves the shot 45 minutes prior to sexual activity. Most common side effects are nausea. I would say that is the #1 side effect that you see between giving yourself that shot and that 45-minute mark. The nausea can last more than 45 minutes. I've seen it last in patients for, up to a day, if not longer. So just be aware that that is a side effect. And again, this is for that person who doesn't want to be on a long-term agent. They just want a, on demand, I want to be able to have sex tonight. So you have to sort of have that discussion with your patient of what seems more appropriate for them. Do they want something that is going to lift their libido and their desire, increase it on a sustainable level, or just something that, I just want this for every now and then. Sensate Focus is a very common sex therapy tool. It was developed by Masters and Johnson. It is basically a homework assignment for your patients who are looking to improve intimacy. They've been in a relationship, either they've never had the sexual intimacy that they wanted, or because of whatever reason, they've lost that sexual intimacy. We tell patients to get into, a room that has sort of a romantic environment, low level lights, candles, whatever works for you. Typically patients are not wearing clothes, and they go through sort of week by week treatment, right? So there's different guidelines on this. So the first would be non-genital touching. So you and your partner are in a bed, you're exploring each other's bodies, there's no talking, and you're you're showing your partner where to touch you on your body that feels good for you, that's not threatening for you, and you're taking their hand and putting it there. The following week or next session, so again, not everybody is week by week, some people need several weeks for each stage. The next stage would go to genital and or breast touching. The next week would go to mutual touching, and then finally sexual intercourse. I've seen patients go through Sensei Focus in a month. I've seen it take up to a year. It really does depend, and the goal is to reduce anxiety around sexual activity, reduce performance anxiety.
Great, thank you so much. I know we're a little short on time, and perhaps we can hit the highlights for the last two cases. And I know this is a patient that you've seen recently.
Yeah, so this is a very common patient in my clinic. I work closely with the breast oncology clinic. So this is a woman, 45 years old. She has pain during penetrative vaginal intercourse. Her history is significant for a stage 1 estrogen receptor positive breast cancer. She is now on adjuvant therapy. So she's gone through her sort of acute treatment. Now she's on her adjunctive therapy or adjuvant therapy, excuse me, which is Zoladex or Glycerin and an AI. She, of course, because her treatment has significant side effects, including hot flashes, night sweats. So very common for women to have menopausal symptoms when they're on these medications. And so she was put on venlafaxine for her symptoms, and she's doing well there. Where she's not doing so well is with the vaginal dryness. So this is the biggest complaint that I see with patients on an aromatase inhibitor. And keep in mind, they're going to be on it, many of these women, for 10 years. This has a huge impact on sexual function and quality of life. So this particular patient had no improvement after 4 months of using a hyaluronic acid vaginal moisturizer. So this is a non-hormonal vaginal moisturizer. She was using it twice a week as directed. She used a water-based lubricant during sex. And because of the pain that she continued to have, and she had pain at entry during penetrative vaginal intercourse, she started avoiding sex with her male partner. She was also getting UTIs every time she had sex. She went to her clinician. They switched her to tamoxifen to see if that would help with her symptoms, and minimal improvement was seen after 6 months. So she was referred to me.
Yeah, and I can tell you in primary, this is one of the great challenges. Many of us are very uncomfortable thinking about treating a patient who's had breast cancer with hormonal treatment. So I'm so glad that you're bringing these issues up.
Yeah, so when you do the exam on this patient, and the picture on the left is not from this particular patient, but I'm giving you an example of what you can see over time of using an AI, is significant vulvar and vaginal atrophy. So you can see on the left, there is a decrease in, for example, pubic hair. We see a thinning out of the labial fat pads. We see clitoral atrophy. So the clitoris itself actually gets smaller. We see sometimes fusion of the clitoral hood to the clitoris, which can affect orgasm. On that bottom left photo, you're actually looking at the glandular ostia of the vestibular glands. Those can become atrophic as well, and you'll actually see erythema when you look at those areas, and you can see some, you can touch with a Q-tip and actually elicit pain. That is very common. When you look inside the vagina, you see pale mucosa, you see loss of rugae. In this particular patient, you sort of saw all of those things. But most importantly, when you did a digital exam on her, you put 2 fingers. So we talk about the caliber of the introitus, so the caliber of the opening, and I measure it by finger breaths, 1 finger breath, 2 finger breaths, whether it's tight or not around my fingers. And for this patient, she had tight 2 finger breaths for her vaginal caliber, all of these contributing to her sexual pain. So what is her diagnosis? Her diagnosis is genitourinary syndrome of menopause. This is basically estrogen deficiency affecting the vulva, vagina, urethra, and bladder. Very common. It affects anywhere between 27 and 84% of midlife and older women. It's chronic and progressive. So if you have women on treatment and then you take them off, the condition is going to start up again. So whereas most menopausal symptoms will eventually go away, GSM typically does not. So we usually see symptoms start when a woman's serum estrogen level is below 50, and you can see a list of all of the symptoms that she may experience. In this patient in particular, it was dryness, pain during sex, and frequent UTI. So this is just a cartoon of what it looks like to have a premenopausal vagina and uterus versus a postmenopausal. So you can see on the postmenopausal side, really a thinning of the vaginal walls. The vaginal canal can get shorter and more narrow, and you just see a sort of pale, dry, smooth lining. So what are the next steps that we do? I mean, to say to a patient, I'm sorry, you're a breast, and believe me, I've heard this from patients who come to see me. They were told, I'm so sorry, there's nothing that I can do. If the vaginal moisturizers aren't working for you, maybe you want to find other ways to be intimate. I've actually heard this from patients. We don't want to do that. There are options available to you as the provider. Recommending a silicone-based lubricant or a natural oil is much better for the patient than recommending a water-based lubricant. Silicone lubricants last longer, they decrease the friction more, and they're much better for patients who have atrophy. Same with the natural oil, except you can't use a natural oil if you're using latex condoms or latex items for safe sex. Offer low-dose local vaginal estrogen therapy or intravaginal DHEA as a treatment plan. So this is where people start to get nervous. It is, in certain situations, it is okay to use vaginal estrogen as a second-line treatment option. We typically don't offer it as a first-line treatment. However, if a patient has failed the first line, which is a non-hormonal vaginal moisturizer and lubricants, then we often will go to vaginal estrogen as long as it is okay with the patient's oncologist. So I always bring the oncologist into it. And then, of course, whether or not we want to use vaginal dilators, absolutely. And these patients who are having vaginal narrowing, you can give them all the estrogen in the world, but if they have a significantly narrowed vaginal canal and introitus, you're going to have them using vaginal dilators. So the two of them, vaginal estrogen and dilators, are probably the most effective approach at treating this kind of condition. This is just a resource for you to use. On the left is an algorithm that sort of takes you through how you want to treat VVA or vulvovaginal atrophy. And on the right is a resource for you. This is a position statement from, we used to call it NAMS, now it's called the Menopause Society, but it is a position statement on the treatment of genitourinary syndrome of menopause. Everybody should have this in their library. Next slide. I think we're going to get into some lubricants. Yeah, lubricants are your best friend. Water-based lubricants, I feel, are best for women who are premenopausal, women who really need just a little bit of lubricant. They are the most widely available. They are safe with latex items. They do dry up quickly. So if you're going to use a water-based lubricant and you tend to find that you're reapplying and reapplying, you can actually have a spray bottle of water next to your bed and actually spray it on the lubricant to reactivate it. For some people, that's a little coitus interruptus, but it can work if you want to not keep applying the lubricant. And there are some that are listed. The silicone-based lubricants, like I said, these are longer lasting, they decrease friction more, and they are better for patients. I'm going to let you know that the one that I always recommend to patients is the Pure Original PJUR that's listed there, but these are all great lubricants that you can recommend. Pure and Uberlube really are available online. It's hard to find them in a CVS or Target, but you have a whole list there that you can recommend to patients, and they are safe to use with silicone products. The natural oils and the petroleum-based oils, again, not to be used with latex. So again, keeping in mind safe sex practices. If you're going to recommend an oil, I recommend the coconut, avocado, corn, olive, any of the natural oils. They are non-irritating versus the petroleum-based like Vaseline or mineral oil or baby oil. Those may promote vaginal inflammation. They're not for use with condoms again. So we tend to sway more towards the natural oil-based, excuse me. The non-hormonal vaginal moisturizers are often a first-line approach for breast cancer survivors who have GSM symptoms. So these can be helpful. What it is essentially is a non-prescription treatment that's over the counter. It's replenishing the water content in the vagina. In some cases, it can improve elasticity, but not as good as vaginal estrogen therapy. Some people will use it as a lubricant, and you can. It will last maybe a little bit longer than your typical water-based lubricant. The issue with the vaginal moisturizers that comes up a lot is, how long can you use these? Is it safe to use them long-term? The truth is we don't have long-term safety and efficacy data. And in fact, there is some data showing that at 12 months, the efficacy of a non-hormonal vaginal moisturizer is the same as a placebo. So just bear in mind, we just don't know how long they'll work for. Low-dose vaginal estrogen therapy. So again, if you're going to go with a low-dose vaginal estrogen therapy in a patient like this, make sure their oncologist is on board. There are different options for delivery. There is a 3-month vaginal estrogen ring, so you just switch it out every 3 months. There are vaginal tablets, or sometimes called inserts. These are very easily used by patients. They tend to be a little less messy than some of the creams, like the vaginal estradiol cream. And you can see that we have listed how you use them. So what the loading dose is versus what the maintenance dose is of each of these. And then the newest one on the block is the vaginal insert on the lower right side called Imvexxy. What we love about Imvexxy is, number one, it is vaginal estradiol in a coconut oil base. It dissolves very quickly, whereas it takes longer for the vaginal tablet to dissolve. The vaginal insert really does dissolve in about 45 minutes to an hour, and it does come available in the lowest strength of any of the vaginal estradiol treatments that are FDA approved. There's a 4 microgram, which is the lowest, and a 10 microgram. For most of my cancer patients, I'm going to start at the 4 microgram dose with the option to increase to the 10 microgram dose. And then this is just an example of a patient. This was shared with me by a colleague of mine who this is his patient. So essentially on the left, you see a woman who has vulvovaginal atrophy, not on treatment, and that's that same person after 3 months on the right of vaginal estrogen therapy. So you can see a significant difference in the appearance of the tissue. One thing that I want to really drive home with everyone is that I've had patients come to me on vulvovaginal estrogen and also using a progesterone. And they were put on the progesterone because they were told, if you're using low dose vaginal estrogen therapy, you need a progesterone. The data actually does not support that. And a progestogen is not necessarily indicated with low dose local vaginal estrogen therapy. We know that when you use these low dose vaginal estrogen therapies, you don't get a significant increase in your serum estradiol level. It is not a meaningful impact. So that's why oncologists and gynecologists are comfortable using them in most of our breast cancer patients as a second-line agent. And then just bear in mind that endometrial safety data beyond a year is lacking with vaginal estrogen therapy. And then this is just a quick, this was a committee opinion from ACOG in 2016, basically talking about the use of vaginal estrogen therapy in patients with breast cancer and endorsing its use as a second-line agent. These are 2 of the non-estrogen treatments that are now available for vulvovaginal atrophy and painful intercourse. One of them is an intravaginal DHEA. DHEA converts intracellularly to testosterone and estrogen, but is not considered an estrogenic product. You use it nightly. It's an intravaginal suppository. The most common side effects that we see with vaginal DHEA is discharge. So people will say, I have a daily discharge from this treatment because it is a daily treatment. But it can be a very effective option for patients who don't want to use vaginal estrogen. But I always remind them that intracellularly, it does convert to estrogen. And then the other one is an oral medication called Osphena, and it is a SERM, so a selective estrogen receptor modulator. It's a 60 milligram daily treatment. Most common side effect are hot flushes, but don't occur that often. It's about 6% of individuals who experience hot flushes. And so again, 2 options for patients who may want to avoid vaginal estrogen therapy. And then I think we have one more slide on this. And vaginal dilators, just to say, vaginal dilators are probably the tool that I send 90% of my patients home with. So typically my protocol for patients, if they have atrophy, they start off using them 5 days a week for about 20 minutes. If they're using a plastic dilator, the one you see on the left, that kit is a silicone-based. But if they're using a plastic set, they're going to use a silicone-based lubricant. If they use a silicone dilator, they need to use water-based lubricant. Having said that, it usually takes a couple of months for patients really to get up to the largest size and for sex to become comfortable once they do the intervention with either a moisturizer or dilators or a vaginal estrogen inhalators. And then lastly, when we're talking about treatment of vulvovaginal atrophy, we have to talk about energy-based therapies. Now, many of you know the lasers such as the Mona Lisa Touch or the Diva. There's also radio frequency devices available. Bear in mind that these are not FDA approved for this indication. The way that lasers work is they create a microtrauma in the vagina, so little cuts in the vagina, and that leads to increased collagen formation, blood vessel formation, and the thickening of the tissue. For most patients who do these laser treatments, first of all, you have to do 3 treatments and then usually a follow-up at 1 year treatment. The long-term outcomes in terms of is this a sustainable treatment for BVA is A, we don't know it, and B, from what we see, this is not a long-term solution. We also know that this treatment is not superior to vaginal estrogen therapy. It's costly. It's generally not covered by insurance. So if you're going to recommend these therapies, I think you also have to share this information that it's not really a first-line option for our patients, but it is available for those who want it.
Great. What a wonderful discussion. I think that hopefully all of you in the audience have gotten a lot of tips about things that you can do to partner with your patients and begin to really improve their quality of life. We're a little over time, and so I'm going to just hit the highlights of this case. This is a case that's going to be familiar to all of the people in primary care. A young woman came in having started a SSRI and went from having a very good, healthy relationship with her female partner to being able to, from having normal orgasms and normal sexual functioning, to really being anorgasmic and being unable to achieve orgasm through partnered sex or masturbation or using any kind of sexual device. Bupropion, which was added on, helped her libido, not her orgasm, and she was fairly well estrogenized. So this is, as you know, female orgasm disorder, which is a persistent or recurring distressing compromise of orgasm frequency. And it can be either primary or it can be acquired. And just to reiterate the highlights of management, which many of you in the audience already know, is please don't stop her SSRI. This is going to lead to antidepressant withdrawal. And consider switching to another antidepressant class of agents. And we'll go over a few of those at the end. And you can add something that I haven't been very familiar with, which is a clitoral suction device, it's a type of vibrator, which you could incorporate into sexual activity. And you can also do some off-label use of Cialis and the PDE 5-1 inhibitors. Dr. Mahoswar, do you want to tell us a little bit about sildenafil?
Sure. So sildenafil, which is a PDE5 inhibitor, is a treatment option for its off-label use for women who have orgasmic disorder as a result of being on an antidepressant. So we know that many of our patients who are on antidepressants will come in not only with libido, but also with delayed or absent orgasm, which can be distressing to them. So there is research that shows that sildenafil can be effective. We typically start with the 50 milligram dose and then go up to 100 milligrams as needed. I've seen patients have excellent results with sildenafil, and I've seen people who are on an antidepressant who, do not improve, but it is an option for those individuals who have tried bupropion as a antidote to sexual dysfunction, which, by the way, typically only helps with libido, and who have already tried vibrators. So typically what I say is incorporate a vibrator after using the sildenafil, and let's see how things go. For those people that it's successful, this is a game changer for them. Also, I want to bring up that antidepressants, when you have a patient who has a sexual concern or problem following onset of one of these SSRIs or SNRIs, think about switching them to a antidepressant with the lowest rate of sexual side effects, and these typically tend to be the ones listed below.
Thank you. And finally, I think that we wanted to talk a little bit about something that many people in primary care may have be less familiar with, and potentially also have a hard time talking to their patients about, which are genital stimulators. So how effective are they, and is one better than the other?
Yeah, so this is actually a slide that was taken from a presentation at the Urogynecologic pelvic floor meeting earlier this month. And I just think that this is great because this is what I hear from my patients in clinical practice too. So they wanted to see what the best vibrator was for optimal orgasm in women, both pre and postmenopausal. They looked at the wand, which is sort of a very popular vibrator out there. They looked at the dual prong that has clitoral and vaginal stimulation, and they looked at one of these clitoral suction devices. And they found what we all now understand in female sexual medicine, which is that these clitoral suction vibrators, and there are so many different ones out there, are the preferred device for achieving orgasm. So for your patients who have difficulty with orgasm, you might want to recommend one of these devices. And I can tell you, because your patient will say, well, where do I buy this? Amazon has every vibrator available under the sun. So that's always a great platform to send them to find a vibrator.
Well, we really want to thank the audience for staying with us. We know we're the last discussion of the day. And just to reiterate a couple highlights. The first is that female sexual concerns are very common in the United States, affecting up to 44% of women. And so please, please inquire about female sexual concerns as a routine part of your practice. And hopefully the tips and techniques that you've heard today will help you develop a framework for how you can begin approaching treatment. Dr. Milhauser, did you want to say a few words?
No, I just want to say that I am so happy that this is a discussion that we're having with primary care, because you as primary care providers, you're the first line. And these are the patients, they are dying for you to ask them about their sexual function and address it. So I am so grateful that you're all here to listen to this talk.
Well, thank you, everyone, and we're open for questions.
Right. Dr. Srinivasan, thank you so much for giving this talk with Dr. Milhauser today. I really do think this is a topic that we don't know or talk enough about in primary care. So thank you both for giving us so much to consider in our practice. So a couple of questions. When would you consider checking testosterone or DHEA in women? What are some symptoms of low T in women other than low libido?
Yeah, so androgen, so as we talked about before, we know that in a postmenopausal woman, her testosterone level is going to be low, right? And that's because her ovaries are not producing the same amount of testosterone as they did prior to menopause. So in those patients, I am not going to be checking testosterone as the cause of her low libido. I'm going to be checking her testosterone if I put her on therapy, and now I'm just following that level to make sure she's not becoming super physiologic on her therapy. In terms of premenopausal women, again, it's pretty uncommon for androgen insufficiency to be the cause of her low libido. But if she's describing, like, everything in my life is great, but in the last few months, whatever it is, I'm having lowered energy, my mood is low, and you've ruled out that this is depression, you know, or anything else, it's very important. Her libido has been low. These may be things that are a sign of androgen insufficiency, and then I might be checking a testosterone level on her.
I see. Thank you. And you mentioned a goal range. What would that be for in women?
So it depends. I mean, I can tell you what the goal range is, and it depends on what your lab is using. So you have to see what your lab is, but you want them sort of in if they're on treatment. Okay, so this is important. If they're on treatment, the range is sort of at the higher level of normal for a premenopausal woman, right? So you don't want to go above that level, but that's if they're on treatment. Remember that there is no testosterone level that is what we would say sort of the gold standard of this is where your libido is going to be good and this is where your libido is going to be bad. Like, there's no cutoff. So testosterone, unless you're looking specifically at a premenopausal woman and you're assessing for androgen insufficiency, her level is going to be at the lower range of normal, so at the bottom of the normal range, right? But there's no level you are looking for to say this is normal, and above this you're going to have good libido, and below this you're going to have bad libido. So again, androgen insufficiency, you're looking at the lower quartiles for the normal range for your lab. That's in premenopausal women. Postmenopausal women, they're all going to look like they have androgen insufficiency because they're all going to have low testosterone levels. And we don't check PHEA. We're checking, for libido, we're checking just total testosterone and free testosterone.
I see. Okay, thank you. I feel like I often get patients who are seeing like an outside doctor or a functional doctor for menopause symptoms, and they're kind of automatically put on testosterone. Any thoughts on the risks of testosterone therapy in women?
Yeah.
When people stop it, etc.
Yeah, we shouldn't be putting women on sort of routinely on testosterone. Yeah. So I've seen that too from patients coming in from the outside who are put on a regimen of estrogen, progesterone, testosterone. Oftentimes we see that being given as a pellet. So we see women coming in on these compounded bioidentical hormones versus the FDA approved bioidentical. Testosterone is used off-label in postmenopausal women for the treatment of chronically low libido. So even though it is off-label and not approved by the FDA, it is the treatment of choice because there is enough data on safety and efficacy to support the use. Now, one thing that I caution all my patients and I make them aware of is your response to testosterone for libido at best will be modest. When I put you on the correct amount that keeps you in the physiologic range, it's going to be a modest response. And why that's important to know is it's not just your testosterone that is causing your low libido. You have to go back to that chart that we talked about and showed where there's all those different factors. As women get older and go through menopause, they're starting to face health issues that might impact their sexual function. They might be on medications that might impact their sexual function. Relationship issues might impact it. Partner sexual dysfunction might impact it. So again, testosterone is not going to fix everything. And we certainly only want to recommend it for chronically low libido in women.
Okay. And do we see the similar kind of rates of cardiovascular risks as we see in men on testosterone? No.
If you look at the data on safety, there was a big meta-analysis done on testosterone use in women, and there have been some studies of medications, like randomized controlled trials that looked at long-term safety. At the dose that we put women on, which again is about 1/10 of the male dose, we do not see increased risk of cardiovascular disease or events. We don't see increases in breast or uterine cancer. We don't see increases in, blood clotting, stroke. So at the low levels we put women on, it's a fairly benign treatment. The most common side effects occur in about 3 to 8% of women at these lower doses, and that's hair growth on the face or body or acne. So it's a fairly well tolerated medication. Women who are not candidates for estrogen are also not candidates for testosterone because it does convert to estrogen in the body as well.
I see. Thank you. Have you had any kind of insurance coverage issues in regards to Addyi and Vyleesi?
Unfortunately, yeah. We oftentimes will have to get a prior authorization for patients, which is a tough pill to swallow sometimes. I mean, this is a very well documented condition. The treatment is FDA approved, but yet it is poorly covered by insurance. So that can sometimes be a detractor for patients, and they don't want to wait for the prior authorization, or they end up deciding they'll stop pursuing treatment. For many patients, if they're going to pay out of pocket, it could be close to $100 a month. If it's covered by insurance, it's about $25 a month. But we don't see unfortunately, the same insurance coverage for treatments for female sexual dysfunction as we do for male sexual dysfunction.
Right.
Yeah, there's definitely a double standard, and you can tell who's making the policies in the nation.
Great. Well, thank you all for kind of concluding this conference with such a high yield topic that, again, I really feel like we don't hear enough about. Do either of you have any last minute comments or suggestions for our attendees?
There was one thing I heard. I was listening to the recording and I was like, oh my God, how did that just come out of my mouth? I think I said, if you don't see improvement with Addyi after 2 weeks, stop the medication. It's not after 2 weeks. If you don't see improvement after 2 months with Addie, then you're going to consider stopping the treatment.
Okay, thank you.
Yeah. And what I would say is that I think that especially when it comes to sex and sexual health, a lot of providers are uncomfortable bringing up these topics with patients. And as we socially situate this in the same way that initially people weren't comfortable talking about end-of-life care or some of these other topics that have a lot of emotion and a lot of personal and cultural baggage, the background, not baggage, built into it, I think that it's important for us to figure out ways that we're comfortable engaging our patients around something that's a very personal and very intimate topic that can really make the quality of your patient's life so much better. And thank you for everyone for coming today.
Thank you, Dr. Milheiser and Dr. Srinivasan.